Noon and good evening, good morning. Thanks so much for joining us from wherever you're joining us today. My name is Amber Murray, and I'm an associate professor of human geography at the School of Geography and the Environment at the University of Oxford. Along with my colleague, Dr. Sneha Krishnan, I co-convene the Political Worlds Research Cluster, which is hosting this exciting event. It's a great privilege to be hosting Dr. Patricia Lopez for our final talk of Hillary term. Dr. Lopez is going to speak today about racial capitalism and care in COVID. We're really pleased that Dr. Lioba Hirsch is returning to the School of Geography and the Environment to act as discussant for today's talk. In a moment, Sneha will introduce our speakers, but I wanted to take the opportunity to encourage our audience members to check out the Soggy YouTube channel, where they can find Dr. Hirsch's excellent talk in our department, which happened earlier this term. That talk was titled Health Mobilities and Diasporic Blackness. And it was a brilliant and insightful examination of the racialization of mobilities during health crises, from Freetown to Hackney. So please do look that up. I'd like to begin by telling you a bit about the Political Worlds Research Cluster, which is the youngest cluster in our school. The Political Worlds Research Cluster is an interdisciplinary collective drawing membership from across the school, as well as scholars outside of geography. Our researchers are concerned with how politics and power are constituted in and across place and space. We seek to develop novel and critical understandings of the relations between geographical knowledges and regimes of discipline and violence. Our work and research broadly fits within the following remit: life, death, and well-being in 20th and 21st century geographies, violence, nonviolence, and disciplining, politics, power, and geopolitics, and geographical knowledges, including the geopolitics of knowledge. We're always keen to grow our numbers, and please do not hesitate to get into touch with either Sneha or myself. I'm including our contact information and our Twitter handle on the slide here. Today's talk is part of our year-long series on power and political lives. Our series will continue with 2 speakers next term, which is Trinity term, including Dr. Ruth Craggs, who's speaking in May on histories of geography in Africa, South African geographers and apartheid in the 1970s and 1980s. Please do look out for those upcoming events. Some housekeeping for today's event. We're recording today's talk, which will also be made available on our website, as well as the department's YouTube channel. Please feel free to type your questions and your comments into the chat box, and we're going to have time for discussion after the talk. So again, I'd like to extend a very warm welcome to our speakers and to our audience members for their time in joining us today. And without further ado, I will turn it over to Sneha for the official introductions.
Thank you so much for that, Amber. I'm just going to introduce today's speaker, Dr. Patricia Lopez, and the talk she'll be giving. Dr. Lopez is an assistant professor of geography at Dartmouth College in the US. She's a health and development geographer who focuses on the impact of US foreign policy on the unfolding of international health and development projects in Haiti over the past 100 years. She's interested in exploring the racialized discourses that have undergirded US interventionism, as well as the social and political responses to these interventions from within Haiti. At the heart of her research is an exploration of the role and accessibility of health citizenship. She has 2 current research projects going. The first is an examination of the impacts of the cholera epidemic in Haiti, both as a catalyst for highlighting the need for a recognized cosmopolitical subjectivity, as well as its reflection of centuries-old racialized outbreak narratives and imaginative geographies. The second is a book project tentatively titled Monstrous Microbes, Geography, Race, and Disease Narratives, in which she examines the co-emergence of new geographies, race and racism, and disease and outbreak narratives during the early years of global exploration, and the hauntings of these onto-epistemologies for marking the boundaries of humanity, and by extension, citizenship. Today's talk is titled Racial Capitalism and Care Under COVID. COVID-19 is the fifth coronavirus to emerge in human populations in the past 2 decades and is the most virulent of the community-spread HCoVs. While COVID-19 has disrupted social life, leading to multiple crises, biomedical, economic, social, and political, it has disproportionately impacted low-income and Black, Indigenous, and people of color communities in the US. The double burden of the outsized impacts on the social and economic lives of BIPOC through heightened exposure, particularly in positions of care, and the intensified severity of illness and death are not accidents of the disease, but rather have been co-produced by the long history of structural racism and racial capitalism in the US, beginning with settler colonialism and slavery, and continuing through its many transformations from Jim Crow to the contemporary undercompensated and undocumented care labor of BIPOC, particularly women. This talk will bring critical political ecologies of health and disease together with racial capitalism and care in order to interrogate the racialization of the disease and the ways in which racial capitalism has fostered this disproportionate burden among Black, Indigenous, and people of color communities. I'm really sorry, I should have emphasized that what I was reading out is the abstract for the talk that Dr. Lopez kindly sent us. Our discussant today is Dr. Lioba Hirsch, who, as Amber mentioned, also delivered the old school seminar earlier this term. And I will introduce Dr. Hirsch after Dr. Lopez has delivered her talk and right before the discussant's comments. Thank you so much. And Tish, I very much look forward to your talk.
Thank you so much for that introduction. It's very robust, and bear with me as I sort of try to get myself situated here. I do have some slides that I'll be sharing with you as I go through this talk. They're rather simple. I just wanted to sort of have a little bit of visual attention as we're moving through. Thank you, Sneha, Amber, and the Political World Research Cluster for the invitation to speak today. And thank you also to Lioba Hirsch for agreeing to be the discussant. And of course, thank you to the audience. I realize you all are coming up to the ends of your terms, as am I. And so we're all a little bit pinched for time and a little bit tired. And so I really appreciate you showing up to be here. Before I start, I just wanted to make a quick comment on the images here. They're all either from Creative Commons domain or they're from my own archives. So I have tried to remember to give attention in good faith. So any missing attributions are completely of my own mistake, and I apologize. So this talk stems from a series of conversations and ongoing research that Dr. Abigail Neely and I have been engaged with since March 2020. While I was on sabbatical in Seattle, the whole city came to a grinding halt in just a matter of days. Even as rural New England, which is where Abigail Neely was at that time, was sitting peacefully as yet unscathed by the growing pandemic. It was clear from the very beginning that the impacts were going to be experienced in wildly different ways. That this idea that we're all in this together was yet one more way in which the differential experiences of some would be flattened by those who profess to speak for all. Much of the essential care labor and non-essential public by low-income workers who are disproportionately Black, Indigenous, people of color, BIPOC, women, and immigrants. They often perform this labor without appropriate protective equipment, and all while contending with a small, vociferous, and growing minority of people who refuse or are unwilling to comply with disease mitigation guidelines. And in fact, this past Tuesday, March 2nd, the governor of Texas declared the economy 100% open and ended the mask mandate for the entire state. Feminist theorists and care geographers have long highlighted the uneven distribution of care laborers along gender, race, immigration status, and class lines. Labor that is and continues to be deeply undervalued, underpaid, and unpaid, pushed to the margins of so-called productive capitalism. But while this pandemic de-invisibilized this labor, very little came of it beyond some few rounds of recognition. It was also quickly made clear by the early signs that certain comorbidities, which are experienced at much higher rates among BIPOC and immigrants, would lead to heavier morbidity or mortality rates among the already medically disenfranchised in the United States, bearing down as it did and still does on the bodies of BIPOC. But it wasn't until The Atlantic published an article from Ibram X. Kendi on April 1, in which he pointed out that even the CDC was not keeping racial and ethnic data, that we really began to understand just how immense this unevenness was becoming. He wondered, perhaps somewhat presciently, quote, maybe some people fear that if racial data were to show that COVID-19 is disproportionately harming people of color, then white people will stop caring. This double burden, the outsized impacts on the social and economic lives through the heightened exposure of BIPOC and intensified severity of illness and death, are not accidents of the disease. Rather, these have been co-produced by the long history of structural racism and racial capitalism in the US, beginning with settler colonialism and slavery and continuing through its many transformations from Jim Crow to the contemporary undercompensated and undocumented labor. A purposeful devaluation that in the US is not simply about feminization of care labor, but is also bound up in anti-Black racism and xenophobia, codified finally in the Fair Labor Standards Act of 1938. It's from within these conversations and consternations that this talk has emerged. So some of this talk actually comes from and is a continuation of the shape and contours of our just published article in the Social Science and Medicine. But what you'll hear today mostly stems from the article that we're currently writing. And so what I'm presenting here is some strands of thought and articulation that we're pulling at, these threads and knots, critical political ecologies of health and disease together with settler colonial racial capitalism and care geographies in order to interrogate both the racialization of the disease and the ways in which settler colonial racial capitalism has fostered this disproportionate burden among BIPOC, as not anomalous, but as the outcome of the deep entrenchment of white supremacy in the United States. In doing this, we are cognizant of Laura Pulido's caution that, quote, most of us examine racial outcomes without considering racial production, and focusing on a particular racial or ethnic group rather than racial capitalism per se may lead to improve conditions for some, but it overlooks capitalism's incessant need to actively produce difference somewhere, end quote. Centuries of this active production, as we show here, arise materially, biomedically, affectively, and socially, structuring crises that are unmistakably fractured along these lines of difference making. I want to start today by giving you a sense of the landscape within which we're working. And I'm about to do precisely what I've started and will end this talk by suggesting that we do not do. However, I realize that the specificities of the experiences in the US may be illegible if I don't. So across the US, Pacific Islanders, Latinx, Black, and Indigenous Americans have twice the mortality rates from COVID-19 than white and Asian Americans, who experience the lowest age-adjusted rates. And as you see here, there's some data missing. So for instance, several states do not collect data about Native Hawaiian and Pacific Islanders in their demographic data. So we're not sure what the caseload is nationwide. Also, the hospitalization and deaths are our best guess, drawn from several sources. The same is true of Native American and Indigenous numbers. Where some states don't keep this data, medical personnel in other states make their best guesses at racial and ethnic identities, and Native Americans and Indigenous people are often misrepresented as white. But those numbers don't really capture the broader geographical particularities. So for reference, and I've circled a few spots on here, just to sort of give you some spatial references, I'm going to be speaking about each one of these very, very briefly. I know I was just in a talk the other day about Arkansas, and I was like, where is this place? And so I thought this might be a little bit helpful. In Washington state, rates of confirmed cases for Native Hawaiian and other Pacific Islander people were 9 times higher than those of white people, while hospitalization rates were 10 times higher than that of white people last July. The numbers were most dramatic in Spokane County, this spot in red, where people from the Marshall Islands make up less than 1% of the country's population, but represent about 30% of confirmed COVID-19 cases. In Arkansas, here on the right, Pacific Islanders are just 0.3% of the population, yet accounted for 8% of the COVID cases. And more specifically, Marshallese, again, who are estimated to make up just 1.5 to 3% of the total population of Benton County and Washington counties, accounted for 19% of COVID cases in the region and 38% of deaths. During the first wave of the pandemic in Louisiana, more than 70% of the people who died from COVID were Black, which represents more than 32% share of the state's population, and well above the 60% share of the population of New Orleans, here in red again, where the outbreak was the worst. In New York, African Americans comprised 9% of the state population and 17% of deaths. And in Milwaukee County, here in Wisconsin, Black people make up 67% of COVID-19 deaths, despite being just 27% of the population. I don't have slides for the next couple of things, but I just wanted to also point out that nationwide, 1 in every 475 Native Americans have died from COVID since the start of the pandemic, compared with 1 in 825 white Americans and 1 in every 645 Black Americans. While there are 574 federally recognized American Indian tribes and Alaska Native villages in the United States, the Navajo Nation, which is the second largest by population, has suffered the greatest losses. But proportionately, Indigenous people in Mississippi have died of COVID at the highest rates of 1 in every 127. At the same time, BIPOC and immigrants make up the largest portion of medical staff. And while we stand at our windows and on our balconies to clap and bang pots and thanks of the nurses and doctors and other frontline healthcare workers, it's worth remembering that physicians, surgeons, and nurses make up only 20% of the total healthcare labor force. The remaining essential workers in healthcare industry are the nursing assistants, the phlebotomists, home health aides, long-term care facility aides, housekeepers, medical assistants, cooks, et cetera, make up the other 80%, earn far less than a living wage, 20% live in poverty, and 40% rely on some form of public assistance, and many work without adequate protective equipment. They also tend to have very low rates of insurance. It's also worth noting that 25% of these low-wage healthcare workers are African-American, 21% are Latinx, and 15 to 22% are immigrants. So I've structured the rest of this talk, and as you can see, it's not really an outline in a linear sense. I want to begin with thinking about political ecologies of health and sort of drawing it forward to talk about racial capitalism in order to pull it back around to sort of these political ecologies of racial capitalism, particularly in the body, so political ecology of the body, and then talk about care and what we've learned and what we can learn from the forms of resistance that erupted and ruptured the pandemic. So political ecologies of health have brought the focus on health and disease out of the sole purview of biomedical processes of the body to encompass what Madison Barber and Julie Guthman call the external, political, and structural conditions that make certain populations vulnerable to disease. As Brian King outlines, political ecology assists in showing how health is situated within political, economic, cultural, and environmental systems that intersect to shape the spread of disease and decision-making options available to human populations. Indeed, a critical political ecology of health and disease necessarily not only moves beyond biomedical constructions of disease, but also takes seriously the histories that produce inequality in response and in resource access and wealth and the construction of racial difference. Which is to say, individual bodies are entangled with social and political bodies, produced in and productive of environments, socio-political processes, and settler colonial racial capitalism, and they must be understood as such. In drawing on racial capitalism, we're centering the differential illness and death of BIPOC due to COVID-19 within longer histories of capital expropriation and exploitation. Theorists of racial capitalism have long argued that capitalist accumulation from its inception has been dependent upon the vulnerability and disposability of particularly racialized bodies. Indeed, as Pulido reminds us, racism is a structuring logic of capitalism, building as it did through expansion of empire. Racial capitalism at once renders subjects vulnerable to hyper-exploitation and expropriation in the economic domain and vulnerable to premature death in the political and social domains. In highlighting the impacts of racial capitalism in relation to COVID-19, we're pushing back against the tendencies within biomedicine to search for clues for differential health and disease among racialized subjects in, for instance, as Dorothy Roberts, Solange Nelson, and Anthony Hatch and others have pointed out, genomic sequencing, which merely reifies the social construction of racial difference. We're also pushing back against the pathologization of individuals' habits as moral failures, as when US Surgeon General Jerome Adams invoked Big Mama and Abuela in his calls to Black and Latinx people to reduce smoking, drug use, and drinking, despite the fact that whites engage in these activities at levels equal to or greater than people of color. Rather, we're concerned here with what Arlene Geronimus and others have called weathering, or the cumulative effects of inequality and racism on the health of African Americans specifically, and people of color generally. On a physiological level, Geronimus and her co-authors tell us, persistent high-effort coping with acute and chronic stressors can have a profound effect on health. The stress inherent in living in a race-conscious society that stigmatizes and disadvantages BIPOC may cause disproportionate physiological deterioration, marking their biological age as far older than their chronological age. Which is to say, the high prevalence of the very comorbidities that make a COVID-19 infection far more severe and more likely to kill, particularly metabolic conditions such as cardiovascular disease, overweight or obesity, type 2 diabetes, and hypertension among BIPOC in the US, are not simply the outcomes of biomedical materiality, but are what Shepard Hughes and Locke call, quote, the dimensions of human distress, i.e. social relations of sickness, end quote. This, we know, has been compounded by the well-documented disparities in access to, quality of, and satisfaction with health care for BIPOC and immigrants, and further, that BIPOC and immigrants are less likely to have health insurance, take longer to seek medical attention, and when they do, are less likely to have their signs and symptoms taken seriously or to be administered a COVID test. The weather and weathering, Christine Sharps insists, transforms Black being. To weather structural racism, the productive powers of settler colonial racial capitalism is to contend with, quote, the weather in which anti-Blackness is pervasive as climate. The weather necessitates changeability and improvisation. It is the atmospheric condition of time and place. It produces new ecologies. These ecologies are both internal and external, held hostage to the social, psychological, and physical environmental surround, the subtle that stretches its tentacles into the body, and the overt that elicits the somatic response of affects settling into the psyche and into the metabolic functions of the body. The subtle emerges in the everyday, the microaggression, the caution, the heightened anxieties linked to survival. The link between biomarkers and social measures, as seen in cortisol levels, sympathetic nerve activity, blood pressure reactivity, cytokine production, and glycated hemoglobin levels, have all been related to socioeconomic status, occupation, birth outcome, and environmental risk. And as Nichols and Del Casino have recently argued, the body is ontologically co-constituted through power-laden relations with more than human actors, microbes, nutrients, air, as well as these affective, non-representable forces. The microbiome, made up as it is of billions of organisms essential for the body to function, is held in a delicate balance, buffeted by biosocial relationships through the dynamic process of embodiment. This microbial ecology, made up of more microbial cells and genes than human ones, has been shown to be both impacted by and to impact stress responses, entangled in biosocial worlds, an ecology within an ecology. Externally and materially, racial capitalism is fundamental to ecologies also of resource extraction, processing, and disposal. In the US, race is the most significant predictor of a person living near contaminated air, water, or soil, and people of color constitute 56% of the population living near toxic waste sites. Communities of color are likely to be exposed to nitrogen dioxide air pollutants, and while exposure to any air pollution lowers our ability to fight off infections and worsens reactions to viruses in people with health challenges like asthma, an early study found that nitrogen dioxide pollution specifically may be one of the most important contributors to fatality caused by the COVID-19 virus. So it's not enough to assert, as Brian King does, that, quote, disease vulnerability is connected to environmental factors and is demonstrated by the concept of environmental justice can be tied to race, ethnicity, class, and other social categories and that experience differential exposure to unhealthy conditions, end quote. But that we must stretch this thinking toward an engagement with racial capitalism in order to, as Pulido asserts, focus greater attention to the essential processes that shaped the modern world, such as colonization, primitive accumulation, slavery, and imperialism. By insisting that we are still living with the legacy of these processes, racial capitalism requires that we place contemporary forms of racial inequality in a materialist, ideological, and historical framework, and that we begin from the stance that racial capitalism produces this differential exposure. So as we move to think through racial capitalism's role in the political ecology of COVID-19, our attention turns to social ontology of relationality. If this disease has done nothing else, it has highlighted the ways in which we are all interconnected, entangled, but not really in this together. Our collective ability to survive this pandemic is dependent upon the healthcare workers who care for sick individuals, the essential workers who keep the shelves stocked, our packages arriving, our foodways moving, our children taught, and upon all of us to take seriously mitigation protocols. My health is dependent upon your willingness and ability to wear a mask, keep your distance, wash your hands, just as yours is dependent upon the same for me. And yet at root, racial capitalism is, as Jody Melamed tells us, a technology of anti-relationality, a technology of reducing collective life to the relations that sustain capitalism. It insists upon the production of differential values, a kind of differentiation through negation. To be sure, Black feminists have long argued for a more sustained engagement with the intersections between race, racism, racial capitalism, and care. And I'm thinking here particularly of the work of Audre Lorde and the Combahee River Collective, Patricia Hill Collins and Bell Hooks, as well as the practices of care exercised through mutual aid organizing that is non-Western and predates colonialism and slavery. In the US, the first Black mutual aid society on record appears in 1780, but earlier ones existed, their historical legacies passed down through oral histories. And geographers and care scholars such as Parvati Raghuram, both in her early work with Claire Madge and Patricia Noxalo, and more recently as solo author, has gone a long way to create the necessary openings in this conversation, drawing on post-colonial interventions and then on intersectionality and race within care geographies. But across all of this, there's been a lack of sustained analysis of the intersections between settler colonial racial capitalism and care ethics that can inform our thinking in the midst of a public health crisis like the one in which we are currently living. What then if care geographies were to take seriously the role that settler colonial racial capitalism has had on this current moment, to entangle it in its messy, fleshy, and fraught formations, and to become ethically attuned to these longer histories as they materialize today, both in this moment of crisis, but also as the past, present, future. Montgomery and Bergman tell us ethical attunement disrupts universalizing moral frameworks. It enables exploration, collective questioning, and the responsiveness that is tuned to the situation at hand. Care ethics offers a response to normative frameworks, such as deontological or Kantian, or utilitarian ethics that posit an impartial and universalist approach to equity and justice. And it stands in contrast to what Joan Tronto calls neoliberalism's work ethic, which frames human relations in individualized and competitive terms. It begins with an ontology of relationality and interdependency, an understanding of reciprocity, a grounding which opens up possibilities for more complex frame of livability. Care under this rubric encompasses all the ways that we can imagine, define, and mobilize it as an affective response, as an active engagement, and as an ethical imperative. As an affective response, care is that sense that we each feel when we become aware of what and want to intercede in the service of the needs of others. As an active engagement, it is the very activities that we engage with in order to meet these needs of others. And yet, as Annie Bartos has reminded us, to care does not necessarily mean to care well. And indeed, Lioba Hirsch cautions there is good reason, historically and contemporarily, to be aware of the ways in which care may be a justification for political and cultural domination, given the way that sites of care have so consistently been entangled with violence, trailing as they do in the wake and in the afterlife of slavery. To care ethically is to be conscientious of the ways in which our affective and active responses might most acutely attend to the stated needs of others, as opposed to our own need to feel like caring subjects, turning those for whom we care into objects of knowledge, ontologically negated in the interest of our beingness. And as we saw in the early weeks and months of the pandemic, there was a heightened attention to the need for essential care laborers for the continuation of all life, as well as a growing recognition of the undervaluation of these laborers, becoming a point around which a new public interest surged. Twitter was awash with adoration for elementary school teachers, calls were made for hazard pay, and in some instances materialized until the interest waned, of course, see for instance, Amazon. And in Seattle, as well as across the country, 2 clumsy C-17 Globemaster 3s flew over, quote, health facilities and places of interest around the region, end quote, directed by Trump as some bizarre show of support to frontline healthcare workers called Operation America Strong. And what you see on the left is the actual flight path that these 2 planes, rather loud planes, took. They flew over hospitals mostly and other sites of interest. And as we saw, as the immense racial and ethnic disparities of the pandemic came into clearer view for a wider public, another form of risk appeared: the extrajudicial murder of Black and Brown people by police. If COVID-19 made plain the ways that systematic racial injustices bear down on the individual bodies, the murder of George Floyd on May 25th highlighted the intensity with which the lives of some truly matter less to many. Across the US, protests erupted, protests for the mattering of Black lives, protests for the freedom to breathe, protests against the ontological negation and ontological terror that police brutality and racial capitalism produce. I'm reminded of Frantz Fanon's words when he said, quote, "We revolt simply because for a variety of reasons we can no longer breathe," end quote. Indeed, a coronavirus survivor himself, Floyd's last words, "I can't breathe," became the mantra of the protests. The protests also sparked nationwide conversations about institutional racism, prompting a surge of cities to adopt legislation that officially declares racism a public health crisis, spurred on perhaps by an open letter signed by more than 1,200 public health officials declaring racism a public health concern. To protest in the midst of a pandemic that literally takes your breath away for the right to breathe free is to, in the words of Christina Sharp, is to aspire to do wake work as a mode of inhabiting and rupturing the episteme with our own lived and unimaginable lives. Still more protests for defunding the police, marking a concerted effort to move away from the masculinist sensibility of care as protection toward a more grounded form of redistribution as care model. Early in the pandemic, an Guardian article identified nearly 100 distinct methods of direct action that span the physical and virtual worlds that emerged in the early months. The pandemic is leading new and innovative tools and strategies for action: pop-up food banks, vacant home reclamation and occupation, crowdsourced hardship funds, free online medical consultation clinics, mass donations of surgical masks, gloves, gowns, goggles, sanitizers. We have also seen digital rallies, Zoom-based teach-ins, seminars on starting mutual aid networks, and youth were holding their weekly climate strikes online and working together to build accessible websites. Here at Dartmouth College, student organizers rallied quickly to set up a mutual aid fund for low-income students. And they've already distributed over $50,000 since April 2020 to help pay for rent, food, and other costs. And disability Rights activists are compiling a digital paper trail on Google Docs of all the ways accommodations have been made for non-disabled people during the coronavirus outbreak as proof that those accommodations can be achieved if there is a will. In Seattle, where the picture on the left is from, protesters created the Capitol Hill Occupied protest in Cal Anderson Park and the adjacent streets. It became a nodal point of care, a food pantry, a free healthcare clinic that provided a full range of primary healthcare services. Social workers provided outreach and made hundreds of points of contact with houseless people and drug and alcohol dependent people. Clergy of all faiths held a spiritual center, and mental health therapists volunteered their time and services for free. There were poetry readings, documentary screenings, a debate and discussion cafe, and even a community garden. Volunteers passed out masks, hand sanitizer, and gloves, and many called it a festive atmosphere until it wasn't. And during the run-up to the election, we saw the emergence of CARE as a major platform of a presidential nominee, the one who won. The president of the United States invoked the idea of the care crisis on national television. But of course, in 2 short months, he has already begun to waver on his promises, most recently with his faltering on the fight for 15, or the fight to raise the minimum wage to $15 an hour, which is about £10.78. We knew things would swing back to business as usual. We thought we had a little more time. But if we've learned anything in this pandemic, it is that there is a political will to care, to sit with the uncomfortability of thinking about and trying to address both the legacies of and the current iteration of settler colonial racial capitalism. And as we set our sights on a post-vaccine COVID world, I want to end by thinking through the future archive of our present. What are the stories that we will tell about this year? Of the 18 months that will have passed before vaccines have been distributed widely in the US, of the years it will take to distribute the vaccine globally, will these numbers, we've just passed the 500,000 mark 2 weeks ago, 2.5 million lives have been lost globally. Will these just be numbers? Will we remember as we look back, as Catherine McKittrick puts it, breathless at the archival numerical evidence that puts pressure on our present system of knowledge? Or is it possible to move beyond the ordinariness that has settled and colonized the US collective memory of the embodied experiences of the expropriation and exploitation of BIPOC to view this archive of the breathless quite literally for what it is, an archive of the violence and vulnerability to premature death marshaled by settler colonial racial capitalism?
Thank you so much for that brilliant talk, Tish. Before I introduce our discussant, Lioba Hirsch, I just want to encourage our audience to submit any questions you have using the Q&A feature or in the comments section. So our discussant today is Dr. Lioba Hirsch, who's a research fellow at the London School of Hygiene and Tropical Medicine. Dr. Hirsch is a qualitative and archival researcher with an interest in the colonial and anti-Black entanglements of Western biomedicine and global health management. Her research is focused on the historical development, contemporary management, and colonial aftermath of British health interventions in West Africa. Thank you so much again for agreeing to discuss Tish's paper, Lioba. And I will pass over to you now. Thanks.
Thank you so much, Sneha, and thank you for inviting me to be a discussant on the paper. It's a real privilege to be able to listen to you, Tish, talk about your research and share your thoughts with us. And yeah, I feel very privileged and very moved as well. I'm going to try and summarize my comments in sort of as eloquent a way as possible, but forgive me if my ideas and thoughts are slightly disjointed. I feel like your paper is one of those papers that ideally you sit with for a while and let your ideas and thoughts sink in, and I think something that I would like to start with is really the methodology of your paper, and I guess something that struck me was whether this paper is an act of care, and I think it really is, and in that it's a call to action, but it's also a really respectful and moving way of accounting for violence and for settler colonial violence and for anti-Blackness in the wake of enslavement and colonialism. And I think the way in which you account for this violence is deeply moving, but more importantly, it's very respectful. And I think that's something that comes up quite a lot in Christina Sharp's work, right? About how do we care for the dead, and I think that's an incredibly difficult question, and it's one that I'm always, I guess, puzzling in my head. But I think your paper is such a powerful, offers such a powerful example and way forward of telling stories about racism and processes of racialization and COVID. And I think that in itself is incredibly worthwhile and incredibly important, especially now. So yeah, I guess the first thing that, and I have lots of disjointed notes here, so forgive me for looking down while I respond to your paper. But yeah, I think one of the first things that struck me was how do we respond to the violence of COVID-19? And I was wondering, and I think that's very much what your paper does, whether racial capitalism and a racial capitalism lens is a methodology of care, and that it highlights the social relations of sickness, as you call them. And I think that's very powerful. I also wonder whether by doing that, racial capitalism pushes biomedicine towards its limits. And the boundaries, well, and its boundaries in terms of being able to account for sorry, let me start that sentence again. I wonder whether a racial capitalism lens allows us to push biomedicine towards its limits and towards the limits of its ability to account for and make sense of health as a social as a social phenomenon and as a collective good, as you call it, especially because biomedicine is so focused on individual bodies and individual health. And I think the analysis that you offer pushes against that really powerfully and points us towards solidarity and collective ideas around health and being that are really important in BIPOC communities. And I think that's the fact that you highlight that is amazing. I also wondered about again, this obviously care is at the center of your work, and it is at the center of my work, so that's what I'm focusing on here. But I guess I wondered about care and data, and you spoke about that at the beginning of your paper, and who do we have data on? And I wondered how we deal with the always delayed collection of data with regards to colonial violence and I think the temporalities of data collection. And I also wondered whether the acts of solidarity that you speak about at the end, whether that is care data, and whether the future archive that you speak about needs to include those acts of, needs to include this care as data in a way, if we have the possibility to oppose or to confront violent data or the absence of data as violence with caring data of our own. And then finally, I'm so glad that you link, and you do it incredibly powerfully and eloquently, how you link with the ideas of weathering and Christina Sharp's idea of weather as anti-Black. And again, I think it's important to think about how COVID-19 offers us ways to talk about weathering and talk about weather as this idea of global anti-Blackness that shapes all of us. And I think I always think of and now I can't remember her name. I always think of this quote that we all live in an anti-Black world, and so white people aren't merely racist, they also live in an anti-Black world, and the anti-Black ideas and structures that structure our thinking structure theirs. And I will, very famous Caribbean writer who inspires Catherine McKittrick, and I just can't remember her name right now, but it will come back to me, and I'm sure you'll tell me in a minute. So I think this idea of bringing Aline Geronimo's ideas around weathering together with Christina Sharp's weather as anti-Blackness is really powerful and important. I had a few more things that, I think just again to say I guess the topic of your paper is one that is incredibly important, but is also incredibly difficult to deal with. And I think your paper deals with the violence that you have to talk about and that you have to talk about incredibly well. Yeah, maybe I'll leave it there. I have a few questions, but I don't know how Sneha and Amber, how we're dealing with the...
Please do pose your questions, Lioba, and then we can. Tish, would you be happy to respond first before we take further questions? Okay, excellent.
Right, and again, apologies for my sort of slightly disjointed thoughts. Well, two questions really. One is maybe I just wondered whether you could expand more on the Fair Labor Standard Act from 1938 that you mentioned at the beginning. I think that'd be really, really helpful. And then I guess the other questions that I have was really very much one of whether you think that racial capitalism offers an analytical lens to push biomedicine and to I guess, yeah, push the supremacy of biomedicine in our understandings, both in geography, but also really in medical sciences, really, and in healthcare. But again, thank you so much. This was an amazing paper, and I feel very privileged to have been able to listen to it.
Well, thank you for your very generous comments. I really appreciate that. You never really know as you're putting it out there. It's like, is this making sense? Especially when you've been thinking about it for so long. So. To the first question, it's a fairly straightforward question, but I think is an important piece of this broader conversation that I start with and I actually end with. The Fair Labor Standards Act of 1938 was essentially meant to put into place worker protections, 8-hour work days, minimum wage floor, et cetera. For the Southern land owning elite of the US, however, what they saw in this they saw it as a socialist program. So and this is around the time that we also have Social Security, which is the single biggest had the single biggest impact on poverty in the United States, right? Finally having something like a pension for the elderly, et cetera. And what it was supposed to do was put into place protections for children, especially. This is, at the height of that sort of concern around the exploitation of children. Southern landowners were actually able to intercede to sort of elect in a sort of a balance to this, to have domestic labor and agricultural labor not included. So to this day, children can still work in fields as young as 9 in Oregon for picking peas and berries, as many hours as they're needed. They can work as young as 12 in summer hours across the country, as young as 10 in Hawaii for picking coffee, right? So, and then there's supposed to be a federal labor sort of law around not working a certain number of hours during the school year. This was all about keeping Black families on the land and doing that labor. And the domestic end of it was about keeping women, and particularly Black women, in domestic labor. And those laws were only just recently slightly shifted in 2013 under Obama, that now actually require overtime pay, right? And actually allow them to, in California, you can now unionize. For years, for the last however long, they were unable to unionize and therefore had no protections. And so this is why I start there. And part of what Biden's platform was coming in, and it was certainly not in the realm of thinking about race, because that's not quite where he's at, but he was certainly thinking about gender and this idea of care and invoking the care crisis is not actually moved since the 1990s. So we've had $7.25 an hour since the 1990s, which is about the same as £5.21 in the UK. And again, what we saw was the GOP, mostly Southern, sort of more rural states, were completely opposed to that, and he actually let it go. It was one of the provisions he was sliding into the current bill. And so that's why I see this sort of repeating, right? It's like it just keeps showing up in these particular deeply racialized ways. I do hope, and this is part of the reason for drawing racial capitalism to your second question, to push against biomedicine. There's always this urge to return to some kind of a genetic marker. And even JAMA, Journal of American Medical Association, had an article out a couple of months ago, again saying, well, there must be some kind of genetic sort of holdover that makes African Americans more susceptible to the disease and more likely to die from it. So we just have to find that gene, and then we'll fix that, right? And the resistance to letting go of these social constructs and recognizing that variability across the African continent, like just between two places, there is wider variability than there is in the whole world in some places. It cannot come through. It's just not working. And my hope is that in drawing on racial capitalism and thinking with Geronimus on weathering, and others who have really, now they're talking about allostatic load, and that's where you start thinking about, all the stress responses, et cetera, that build up over time. That we can actually sort of give it a line of entry point through racial capitalism to understand the intergenerational trauma and long-term effects, even epigenetically, without, again, as I think it's Julie Guthman writes about this, right? Like she warns against epigenetics just becoming yet one more way in which we sort of define the sort of epigenetic response as a racial response that's sort of encoded racially. I tend to be very hopeful, though. Somebody recently asked me about that, and I was like, well, if they can't be hopeful, then what's the point? I do also see this starting to happen. There's a lovely paper just out, and I'm going to butcher her name, so bear with me while I grab her name, looking at race and the microbiome, because this is the new realm of racial science, right? There's this attempt to figure out what the biomes of different racial groups, or racial and ethnic groups are. As if that can be explained away. It's either geography or race, but it always comes back to sort of these a priori defined differentiations, rather than that understanding that that differentiation is both a product of and a necessary component of racial capitalism itself, as opposed to a natural sort of existence. So.
Brilliant. Thank you so much for that, Tish. We do have a question that's been submitted in the questions, and I might jump on that and ask a question of my own as well. So an anonymous attendee says, wow, that was really good. Can you elaborate more on the mobilization of care in a racialized and uneven state? Do you see challenges or have critiques of what is happening now in the US to respond to these health inequities? I realize this is a broad question, but I can't think of a way to narrow it more. So your thoughts or reflections are welcome. So the question that I had, which I'm just going to jump on the back of that one, is to do with cruel optimism, which I kept thinking about as you were talking. And it's something that I've been discussing with my students this past week as well in the context of racial capitalism. And especially as you were talking about the people who've had to continue to work during COVID. I was thinking in some ways about the way, the fact that the forms of care they're performing also entail certain kinds of attachments to the very system that is draining them. So I just wondered if you had any thoughts on cruel optimism in the context of care and racial capital. Thank you.
Yes, thank you for both those questions. So I've just read Joyful Militancy with my students. And I think that's the first time where I felt that there was a way to think forward that wasn't trapped in the binary of cruel or happiness, or, the sort of these emotions. And the way that they explain it, I think, is what's most important, is that to think of joyful activism, of joyful collectivity, is actually sitting in the discomfort as well. That it's not about happiness, which is about a subjectification of the self, but the affect as an opening up for and a possibility for transformation of joyfulness. And that's what I saw a lot of in the collective organizing that was going on, and that we see among nurses. I don't know if you're on TikTok, but they do some of the best dances. They're finding their ways to hold it together, but they're exhausted. They're absolutely exhausted. There's no hazard pay. We're still dealing with shortages of PPE in certain places. Some of these hospitals had to go to crisis triage in the United States, which meant they had to make decisions about who was going to receive care because of a lack of access to it. So I do worry about sometimes having too much optimism, right? That becomes another sort of crutch against which to sort of not work towards what we need to see happen. But at the same time, I feel like without an attention to what has been made possible outside of those very institutions that are reproducing racial capitalism, right? That are being, like, through these collective actions in the street is where we're actually, I'm hoping, to find the political will to make that difference, right, in a more meaningful way. I'm not sure if that fully answers your question, but it is something I struggle with and I have been thinking about quite a bit. That, you know, if you go like the full mutual aid, full anarchist, joyful militancy, you know, maybe this won't be a question in a few years. But I joke, but I think there's hope in sort of thinking about the undoing of these systems, and particularly around racial capitalism. To the Q&A question, you know, there is sort of mobilization of care in a racialized and uneven state. You know, the difficulty is that so much of this labor is being performed by low income and people of color, and that the state itself is not responding. However, and this, Abigail and I just have a paper out in Social Science and Medicine actually talking about the entanglements between the individual social and political bodies, exactly like sort of addressing this question, right? For as much as some, like my students, bless them, recently said, oh, what about the failed protests of the summer? And I was like, they're not failed. They created these changes, and we're not going to have the explosive revolutionary change that we want. But for instance, a new study just came out that cities that had sustained defund the police protests actually saw a significant decrease in police violence and in murders of Black and brown men. You know, we see this introduction of public health policies and sort of statements that racism is a public health issue. It's now becoming sort of embedded into the social determinants of health, mostly because of sort of the ways in which excess brutality against BIPOC are sort of exercised on the regular, in this very almost seemingly made to be mundane, but extraordinarily unsettling and violent ways. And in terms of responding to health inequities, yeah, that's always a tough one. You know, this is what I worked on for the last 20 years. How do we do this? I can say that I come to all of this work from having worked at a place that was originally built in Seattle. Their sort of tagline was a Black clinic for Black children, quality care with dignity. And it was built actually by community members. It was over 100 community groups came together in the 1960s to build this clinic. And at the root of that was this highly attuned sensibility about the necessity of an attention to what at that point they weren't calling racial capitalism, but the impacts of race and racism, and also to making possible the flourishing of Black children in an otherwise what was called blighted neighborhood that had been absolutely abandoned by the city and the state generally. And so one of the things that I learned while working there was where there is that sort of political and historical legacy of a particular kind of care, that it also flourishes alongside those children. And it's still, for me, the standard against which I imagine what could be possible in terms of a more caring health system. And this is a big issue around care, right? Like what are the scalar limits of care ethics? I mean, I'm posing that question back. I keep coming up against it because people want to, you know, it's like, how do we actually navigate sort of when it becomes relational? What are the bounds of that relationality and thinking through that care? So I hope I answered your question, anonymous attendee.
Thank you so much, Tish. Both of those answers, I think, were really thoughtful. And as you say, I think some of these questions are questions we're going to be thinking about for a good long time to come, I think. We do have one final question, which I hope we can take. So Kayla Caldwell says, thank you, Tish. I really appreciated how you situated the pandemic as an archive of the violence to premature death. I'm wondering if you would also extend that framework of the archive to crises in general.
Very good question. I mean, I can think immediately within the United States the ways in which we could do that. You know, for instance, Hurricane Katrina in New Orleans, right? There was so much work, and there is still an immense amount of work that has continued after Hurricane Katrina, again through mutual aid, again through Black feminists, liberationists, amazing women, who in that moment found ways to not only collectivize for that crisis, but beyond that crisis, recognizing that racial capitalism in the United States is an ongoing crisis. So maybe in that sense, we could say yes, or maybe we could make it a framework for the archive of the crisis of racial capitalism broadly. I have to think through that, but that's a really prodding question. That's actually, excuse me while I write that down. It's an amazing question.
Thank you so much for that, Tish. And thank you again to both Tish and Lioba for a really brilliant talk and conversation around racial capitalism and care in this moment of the long pandemic. So this, I think, brings us to the end. Thanks to everyone who was able to attend not only this talk, but the whole series that we've had throughout this term. And it's lovely to be able to end on such a brilliant note. Thanks, everyone.
Thank you. I really appreciate it. Thank you, Lioba.
Thank
Nice
you.
to meet you.
Likewise. Thank you, Sneha and Mary, for organizing the series. It was great.
Yeah,
Good to see you again. Bye.